Well, thank you very much. It's really a great honor and privilege and pleasure to be here and to be talking after the end of this really exciting and process of really trying to decide about the kind of difficult decision of making a career change and a life change. And as people who have gone through this process might know, it's something that's initially filled with all kinds of anticipatory anxiety because you're trading something that is known, very concrete to you, for something that's very much kind of, filled with promise, filled with hope, but also something that is ambiguous in a way, something that you don't know very much about. And in a way, trading something that's known for trading something that's full of promise is, on one hand, the catalyst for a particular form of change, but it also is difficult because you're, of course, leaving known structures and relationships and institutions. And I'm really so grateful for the community here because that process has been really made so easy by the welcoming kind of intellectual environment and social environment that's been present here. So I am very grateful that Tony had to eat his words about that. I'm also kind of laughing because in psychotherapy, I mean, different people actually have different views about this, but my personal view is that you should hide the clock from the patient so that they're not always like looking at the clock and saying like, oh, I have 5 more minutes to go before I get out of here. And I'm just laughing because the clock in this room is just sitting right here where I can see it, but you guys can't. So I'll be the one who decides when we start wrapping up. No, I'm just kidding. I'm just kidding about that. But anyway, so as I say, it's really an honor to be here and an honor to be speaking here. This is a process that really started when I was sitting in front of my computer at Michigan when Liz Lenbeck initially contacted me. And I did initially say, well, it's hard for me to think about leaving Michigan. And really through ongoing, and I say ongoing with some emphasis, conversations between the dean and Catherine and other people here, really what was initially a kind of an ambiguous reality became a real reality, and really started to see through our conversations about institution building what that process might look like. Now, I would say that that as I mentioned, there are certain aspects of moving to Nashville that are particularly different from the University of Michigan. And when my friends call me from Michigan and they say, how's life here? And I can only utter 3 words, it's often Robert's Western Wear, which is something that will get them to come here. And I've had friends now come from New York, and I have to say there's no place like that around in Michigan. So that itself has been worth the transition. But I would also say that that beneath the kind of party atmosphere, no, I'm just kidding. But beneath that aspect of it here, that really there is an aspect that is we've been very hard at work in MHS over the course of the summer, over the course of the year, really trying to do several things. And I'd say that the 2 main things that we've been doing that I'll be talking about over the course of my comments today are, first of all, to build infrastructure. So MHS, as people know, and as I'll be talking about in a minute here, is a center that has a relatively brief history in relation to the history of other centers and programs and the history of institution. But what we've been trying to do is build various forms of infrastructure, and some of those are what I'll be presenting for you today. And the other thing I've been doing is going around campus and at least starting to meet with people who've had connections to MHS in the past to ask the question, what kind of things worked in MHS and what kind of things might we change? Now, I'm not in any way saying that my meetings so far have been, as extensive as they need to be, but I will say that over the course of those interactions, some themes have developed that I think are useful to maybe think about as we think about going forward. Now, I hope that this is a kind of annual event where we actually have a public conversation, or at least a conversation for people core to MHS, talking about what's the best direction. And really the key question is, what's the best use of a center within the context of Vanderbilt University? How can a center be the most useful for the community, for the students, for the faculty? And I hope that by the time next year that I give this talk, that we will have actual data for, here's what we started to implement, here are our outcomes, or the beginning of our outcomes, here are our rubrics. At this point, I really just want to give some of my kind of fundamental thoughts that, again, have arisen from these particular conversations, really as a way of opening a conversation, a communal conversation about the best way to utilize this resource, MHS, in the broader Vanderbilt community. So let me just start with a bit of prehistory, which is probably known, certainly known to a lot of people in this room, but of course was news to me coming in. But Matt Ramsey, the founding director of MHS, was kind enough to share with me some of the early annual reports of MHS, and it's been really terrific for me to read through and see the process that started with a relatively small faculty planning group, then a workshop series at the Warren Center, then MHS became a minor, and then MHS became a major. And the different ways, of course, this is like a very grave injustice to the tremendous amount of work that went into this particular history. But what's interesting for me is that MHS, which again probably is well known to everyone here, MHS became an official major only in 2005. And then in 2006 and 2007, MHS developed a master's program. And then from 2009, for an ongoing eternity, it negotiated for a new director, a process that then came to a conclusion. And so really, I think that if we've started to kind of quantify some of what happens with that, and I think two places to look at the advent of the impact of MHS have been in terms of the number of courses and the number of majors. And Courtney Muse is here, who's been helping me put together some of the information about this. And you can see that just in terms of the number of courses that are MHS listed only undergraduate courses, we see really what we might call a kind of mini explosion between 2004, 2005 to the present year, going from 2 classes initially to 24. And people here who are involved in the major also probably know that the graphs of the number of majors similarly have gone, well, I mean, in the academic world, this is a pretty good growth graph, I would say. So, if this was like, our TI-CREF investment, retirement portfolio or something like that, we would all be very happy. And so, really have gone from, again, 3 majors in 2004, 2005, to what I think we could call a whopping 364 majors in the last calendar year. So really a dramatic expansion in the number of majors. Again, this is just at the undergraduate level, not counting the minors, the master's students, and other people who are taking MHS courses. Now, in its current iteration, MHS it has a robust undergraduate curriculum, as you might have guessed from those slides. So we have a major, we have a minor, we have a 4+1 program that really straddles between the undergraduate and graduate world. I think we have some of our 4+1 students here. We have a student board that really just tells us what we're doing and tells us what works and what doesn't. We also have what is at the present moment a freestanding master's program. So 2 of our master's students are here today also, who are getting master's degrees in MHS. And of course, we have a certain number of core faculty. So we've got myself, we've got 3 outstanding lecturers, 1 administrative person who really runs the entire thing and holds it all together, Lynn. And a fantastic list of affiliated faculty. So really, I mean, that's really what keeps this program going, are the connections to the faculty who are affiliated with MHS. And let me say just clearly, because I think that's one of the main messages of this early portion of the talk, that what that represents, among other things, is a success story. In other words, the graph that some people might see as being, whatever, that goes from 3 majors in the very beginning to, coming up on 400 majors, is the result of foresight. It's the result of planning, and more than anything, it's the result of tremendous effort. And so people really have worked incredibly hard to foster that particular success. And I just want to be very clear that what part of this lecture is in no way to disrespect that at all, because I think that none of us would be sitting here or standing here today without those efforts. And at the same time, I would also say, in conversations around the campus and just in terms of my own questions about MHS, that success raises a series of questions that I think are important to keep in mind. Perhaps as I kind of lead toward, after I get through my comments, an open conversation about MHS. And so question number one is, why did MHS grow so quickly and to what effect? Was it that, was it something particular to the major? Was it something particular to the topic area? Was it something particular to Vanderbilt? I think it's a complicated question, not quite as straightforward as we might think. What are the positives of that growth? Certainly having a large number of majors is a good thing. I see it as an incredibly good thing, but it also brings with it certain pitfalls about really I think, awareness about rapid growth and what does rapid growth mean and what should we do to think about that, and how should we think about answers to those questions as MHS moves forward. Now, the key points that I want to make today are that, first of all, the growth of MHS did not happen in a vacuum. That the kind of exponential growth in MHS courses and majors is in part something particular to Vanderbilt, but it's also something that's reflective of a series of larger trajectories and trends about medical knowledge. Second point is that such trends are instructive. They help us identify new forms of knowledge, new forms of thinking, new forms of inquiry. And I think that thinking about MHS in that way helps us think about different ways that we can go forward as a community in thinking about the question that Catherine introduced me with, which is, what are the next steps for MHS? And I think the fourth point, but really the most important point, and the point I hope to come back to again and again, is that my personal feeling, just based on my experiences, are that centers work best when they are not. I've seen different models of centers, I'll just say. I was at the University at Michigan. We started a center called Culture, Health, and Medicine, kind of similar to MHS, but on a smaller scale. I've been involved in different institutes at the University of Michigan, and then I've been at NYU for the past year and a half, and I've been involved in certain centers like the Institute for the Production of Knowledge there. And I've seen different forms of center building, and I would just say that there are two kinds of centers in my mind. One kind of center is the center that walls itself off and functions as an autonomous unit within a university. So you kind of get announcements about stuff they're doing every once in a while, but really it's kind of an engine in and of itself. I love NYU, but I would have to say that's the NYU model. And the other kind of center is a kind of center that is itself reflective of the communal efforts. In other words, people see it as their own, even people who are not part of that center, because it's something that evolves from the communal actions of a community. And I feel like, particularly at Vanderbilt, but just also philosophically, centers work the best when they function in the second model. I mean, unless they have $1 billion because they won the lottery or something like that. But even then, I still think they're missing their social mission if they're based in a university. That centers work the best when they are in conversation and dialogue with other centers and with disciplines in ways that enhance the communal conversation. So that's kind of behind what I'm saying. So just quickly as I go through, I'm going to talk a little bit about the rationale for MHS and addressing the question I asked before. I'm going to say a few words about current strengths and limitations. I'm going to talk a bit about what we've been up to and our plans for the future. And then I'd like, if we have time left, to have, again, an open conversation about really what we see as the role of MHS. There's a seat right there. So let me start with a question. Why should Vanderbilt house an MHS center in the first place? Again, I know the history of centers at the different institutions I've been at, and centers are complicated things. Sometimes they are here, sometimes they are not here. Right there's a seat. Yeah, no problem. But if I had to answer the question of why is it that Vanderbilt should house a center for MHS, the first answer I would give is in relation to medical knowledge. And really, I think that my sense of medical knowledge is that the ways that we think about medicine, medical treatments, even medical knowledge that's just used to be possibly the kind of privy of a physician, is not anymore a top-down process. Now, that might have been how we defined medical knowledge at a prior point in time, but I think increasingly in our society, medical knowledge is something that is the result of an ongoing dialogue between social, cultural, and communal points of view. Different people have talked about this in different ways. I'm thankful to Shug because we were talking yesterday in our faculty meeting about Arthur Frank's notion of shifting from modern medicine to postmodern medicine, the first form being a form of medicine that was the kind of sage knowledge of the doctor, to postmodern medicine, which is more driven by a respect for the knowledge of the populace, or in cultural theory, you might call that a shift from knowledge to knowledges. Now, in no way am I saying that this is any way a disrespect of the specialized training that I and many physicians go through. And so, in other words, you don't want to go to a doctor and say, "Doctor, my arm's hurting," and the doctor is going to say, "Well, what do you think?" I mean, there is a role for, for expert knowledge. So I'm not trying to read against expert knowledge, but I will say that increasingly in our present day, that you can think about the role of the internet, of pharmaceutical advertising, of the dissemination of medical knowledge in different ways that is not only disseminated through culture, but also articulated through culture in ways that impact the ways that doctors think about illness and health. And so there really is a bi-directional flow of medical knowledge that I think is increasingly important to take account of, and particularly because I think that understanding medical knowledge that way helps us destabilize seemingly straightforward terms. And I'll just give you two particular terms from my own research. One idea of why I think we can think of knowledge in a kind of bi-directional fashion has to do with the idea of a disease or of an illness. Now, if you look in a medical textbook, or if you look it up on Wikipedia or in the Oxford English Dictionary or something, you can see that a disease is assumed to be a problem that's basically suffered by a patient and then diagnosed by a doctor. But I will say that this very notion of disease, even though it functions in the medical arena, of course, quite strongly, is in some ways in tension with a number of recent works in what we might call the social, cultural, political history of the ways that illness narratives and definitions of illness are being defined and articulated through works that either are coming from medicine or are potentially coming from people in the social sciences and the humanities who really are deepening our idea of what an illness means. And a few that we might think about, Emily Martin has got a terrific new book about bipolar disorder where she's talking about the different avenues of not only psychiatry but also corporate interests and business interests that are shaping what we mean by bipolar disorder. For people who haven't seen Keith Walu, the historian's new book about cancer, he talks about really the racialization of cancer. There's tremendous new work, again, coming out of Rutgers by Keith and other people, talking about the politics of sexually transmitted diseases. These are just a few kind of random examples. People in the international perspective looking at colonial aspects of psychiatry. My colleague at Michigan, Anna Kirkland, is writing about the so-called obesity epidemic and really taking a very hard look at the definitions of obesity and showing how they are in part due to cultural aesthetics in addition to medical definitions, and really how medical definitions of obesity are shaped by cultural dialogues. And sociology professors like Alondra Nelson, who we'll be hearing about in a little bit here, looking at really the public health model. And I will say that my own work is at the nexus of this particular, if we're defining this nexus, it's a nexus of taking seriously the discourse of medicine, but also looking at how social and cultural factors influence not just popular understandings of medicine, but also medical understandings of what illness and health is. My first book, Prozac on the Couch, was a history of depression and pharmaceutical advertising, and I really used in that case not only medical reports of depression, but also pharmaceutical advertisements and cultural representations to show how understandings of depression were gendered in American society in a very particular way. And so I looked at, for example, advertisements from the 1950s and showed how representations of psychotropic medications and psychiatric drugs really reflected not only evolving psychopharmaceutical information, but also increasing fears of the kind of enlarged married white woman and the role of the woman in the maternal home. And in the 1960s and 1970s, I looked at a host of representations of Valium and showed how, for example, pharmaceutical advertisements all of a sudden showed single, threatening, feminist white women who were themselves kind of the markers of the need for treatment. And in my most recent book, The Protest Psychosis, I've taken this to a different level. So if my first project was about the ways that popular anxieties about gender shaped popular attitudes about depression, the second project looks at the ways that popular anxieties about race, particularly in the 1960s and 1970s during the height of the civil rights era, shaped conversations about psychosis. And I look at advertisements like this one that happened right after the Detroit riots and show how basically all of a sudden this vector of what psychosis was in medical journals. And I should say that the ads I'm showing you are actually all from the American Journal of Psychiatry and Archives of General Psychiatry. So from medical journals, all of a sudden shaped and were reflected by mores and anxieties, not just about evolving ideas about illness, but also shaping illness in terms of anxieties about the particular moment. And I want to also say that using that method, I also have been able to show not just that that showed up in advertisements, but we're doing an ongoing series of projects, for example, now that looks at the ways in which cultural anxieties about race also shaped a series of interventions that were presented in case studies in medical journals and psychiatric journals. So I want to be clear that it's not just about cultural representation, but what we're trying to do, and I say we as scholars who are taking this approach to medicine, is show how the politics of particular moments shape not only popular understandings of an illness, but also shape the ways that medicine itself shapes those. And these are stark examples. Now, in a more recent project, I said that I was going to talk about two terms. The first one was illness or disease. And second, using examples from the present day, is that health. Health is something that should have a straightforward definition. Health should be defined as the absence of disease. But I will say that health is a very complicated term at this particular moment. And if you don't believe me, just turn on the news any particular night, where we see a host of politicians arguing about who gets to define health and what does health mean. And so this term that seemingly we should all agree on is something that all of a sudden relates to, for example, who's getting the HPV vaccine. For people who are following this Michelle Bachmann kind of debate about HPV, it really is who gets to define what my health is. I can say a lot more about that, but that's not the topic of this particular topic, except to say that a seemingly straightforward term like that is also complicated by the healthcare law. So we saw another example of the ways that the definition of health is politicized in the debate about Obama's healthcare plan that's kind of ongoing. And it really was, for me, the first time where people were standing up at town hall meetings and very full-throatedly all of a sudden saying, you're not going to decide what my health is, or I don't want health insurance, or really what they were saying was your definition of health is very different from mine. Now, I would say in relation to this health thing, just as one very quick aside, because it's a project that I'm working on right now, that the debate about the healthcare legislation has been framed very much as a debate about differing ideas of care. That in a way it's like you determine that who's giving money for what particular treatments. But if you look at the examples of where the political disagreements are, you see that beneath all of the logic of who's going to pay for what that shaped the public debate about the healthcare plan are differing ideologies about really what health means. And my favorite example of this actually happened over the course of last academic year, where there was this kind of famous debate between Michelle Obama and Sarah Palin about health, where Obama, people remember this, she was speaking at an NAACP conference, and she gave her famous "dessert is not a right" talk, where she was talking about an anti-obesity campaign. And then Sarah Palin went to public schools, or I think it was Christian schools, and started hand-delivering cookies in Pennsylvania and started saying, your definition of health is not mine, and the government is not going to tell me who's going to be healthy or what to do or how to exercise. Now, I would also say that health is a cultural aesthetic, and so people who look at, for example, I teach a class called Men's Health. I have them look at, different health magazines and ask them what the definition of health is, and it's of course something that's very different from a medical idea of health. We also see health as a moral campaign. I'm not going to go too much into this except to say that a lot of public health campaigns, there are a lot of anti-smoking campaigns, for example, in Michigan, where I'm coming from, that use the rhetoric of health to talk about parents being bad parents if they're imparting secondhand smoke to children. And of course, health also has profound economic and financial implications as well. So a corporate definition of health, and we know, for example, from just following the business pages that the idea of what is healthy for a particular corporation might not be the same thing as what's healthy for a particular body. And so this is just a very quick example, but I guess the point, again, that I'm trying to make is that these terms are complicated and they are politicized, and to not take account in a systematic way of the ways that just seemingly straightforward terms about illness and health accrue political meanings is in part to miss the boat in a way for the ways that this is taking place. Now, people, of course, in this room are from a variety of disciplines, and so there is a long history in sociology, anthropology, literary studies of unpacking different definitions of health. So we know terms like medicalization for sociologists who are here, or framing disease for historians and Charles Rosenberg fans who are here, and Foucault for basically all of us everywhere. But I will say that I feel like the present moment really suggests that there has been a widening of this particular form, of the importance of this particular form of critical thinking. That in a way, the idea of thinking critically about canonical definitions of illness and health is something that's being increasingly valued, not just the way it used to be, which was as a critique or an attack on medicine from the outside, but actually as a value system that's increasingly appearing within medicine itself as it seeks to understand its role in an increasingly complicated world. And several places that we might see that kind of critical thinking is making its way into at least medical education. One, for people who are following the current kind of progress reports as they revamp the MCAT, the test that people here might have taken or know and love, that you kind of have to take if you want to get into medical school. But there are new sections they're talking about for the MCATs. There are 4 sections, 2 have to do with hard science. But then there's this third section, social and behavioral science, and it's using concepts in social and behavioral sciences, statistics, using sociology and psychology concepts to basically think critically. And the fourth new area of the MCAT is critical analysis and reasoning skills. Verbal and reasoning tests, analyzing population health, social science, humanities, etc. Now this all sounds like a humanities curriculum or a social science humanities curriculum in a particular way. And it's, in a way, I'm sure like, where was he? People like Foucault or Irving Zola would maybe be pleased in a certain kind of way, because this is language that's coming from critical theory, and it's working its way into the MCATs. It's also working its way into the Association of American Medical Colleges core competencies, the things that you need to teach people in medical school. So people can look at that database, for example, and all of a sudden we see the increased importance of critical thinking, cross-cultural analysis, writing, reading skills, and teamwork, which is a pretty charged term as they're defining it. But again, this is something that's coming from interdisciplinarity in a particular way. And I would also say that these skills are important for medical practitioners increasingly, because even if you memorize all the facts, even if you know all of the knowledge, doctors are increasingly presented with situations in which what we might kind of falsely call the cultural realm and the medical realm are coming into contact. And one straightforward example of that are doctors who are going into their patients who are going into their doctor's office to ask their doctor for, you name the medication, Zyprexa or Viagra or Prozac or something like that. That's a moment in which that knowing just the chemical properties of a particular medication are not enough. There's also increased evidence that the flow is going in the other direction as well. And so there are increased examples, I would also say, of people from the humanities trying to bridge the gap and accrue scientific knowledge as a way of enhancing humanities scholarship. And I know this because a number of my colleagues from women's studies have actually been attending this neuroscience boot camp at Penn, which is actually a neuroscience boot camp largely for humanities professionals. They started it off because it was for lawyers, but actually an increasing number of feminist theorists who are working on neuroscience are going to learn these kind of core foundational principles in neuroscience. And so there are ways in which there's a new, I think, a new aura, a new kind of something in the air about a new engagement of the humanities with critical science. And of course, people who follow funding trajectories also know that funding is increasingly interdisciplinary along the lines of what I'm describing. So you see Robert Wood Johnson trying to emphasize team-based competencies or social determinants of health grants that ask for team-based approaches. So I would say that this is a kind of long aside for the justification of MHS, and I apologize. But I would say that I think this point is really important to cover in an introductory lecture, because I think that MHS, in the best of all possible worlds, can function as a node for combining these various forms of expertise. As I say here, a site that advances different disciplinary perspectives and really enables their growth as a way of enhancing not just the disciplines, but also rethinking the skills and competencies about what we want to think about people entering into the field of kind of the social politics of medicine might need. And of course, I know that that's something that bioethics and other avenues are involved in, but I would say that I see that as a core mission of MHS. I'll just say very quickly that I think there's a second rationale for MHS, and that's a competitive rationale, which is that there's been a transformation can we just turn that back on? Would that be possible? Sorry. Could people not see the slides? No. Okay, sure. Yeah. That there's a competitive, can we get them both? Can we hit them all up? Anyway, that there's a competitive rationale for thinking about MHS, and that is an evolution of the field. That in a way, MHS results from trajectories that are happening across the country in relation to a discipline that used to be called medical humanities. Now, initially, medical humanities programs, and I'm oversimplifying greatly, were largely based in medical schools. They often, I'm a product of a medical humanities program, and so I'm not in any way trying to be disrespectful of this particular history. But I will say that there were increasing critiques of traditional medical humanities for the structures that they were kind of a part of, which were programs that were part of medical schools and were in a way using the tools of one discipline, using literature. Again, this is a mixed bag. I'm not saying this is entirely bad, but using literature to make better doctors, using literature to make more sensitive or empathic doctors. In a way, the problem with that, I think people pointed out who are critical of this, is that what you're doing is you're putting one discipline in the service of another discipline, and you're not really having an interdisciplinary dialogue because one discipline remains in the kind of established power structure and the other is put in a utilitarian role. And so for various funding and intellectual reasons, we've seen the advent of a series of new kinds of centers across, really across the globe in a way that sound very much like what we hope to do at MHS. So you see programs at Yale, at Penn, at Melbourne, at Stanford, Hopkins, Harvard, et cetera, that are all trying to look at really the relationships between medicine and culture, not so much through the old model of medical humanities, but through a new engagement that's based in social sciences, that's based in other kinds of approaches. And we've been working at MHS, Julie Petty's here, and she's been kind of taking the lead on this, to do a comparison project of what ways, this is a lot of text, and I don't mean to read it all through, but I'm just saying that what we're doing at MHS is doing an extensive comparison project as the groundwork for our first initiative to kind of see how does MHS differ from existing programs? In what ways are our strengths and limitations linked to other programs? And what we're doing is actually coming up with a set of key strengths and limitations that might help us compare MHS to other programs really across the academic spectrum. Now, I will say, just to point out a few of these, that as you might have seen from the list of those other programs are often traditionally based in disciplines. So you'll see something that's based in a history department, for example. There's often a continuity of graduate programs. MHS is different in that it has a freestanding master's as opposed to having a program that's part of a larger PhD structure, which a lot of the other units have. There's a lot of research coming out of the other centers that is actually based in the core faculty of those centers. And they also have, I think, a fair amount more data about outcomes, really about what, because they're more disciplinary based, what their students are going on to do. And I'd say that we haven't been so strong about that in MHS. But what we do have in MHS is a highly diverse faculty and student body. So if you look at just the list of the people who are involved in MHS, we've got buy-in from every part of this campus. It's truly, truly unique. It gives us a lot of flexibility. We're integrated into the community. We've got the support, thank you, of the higher administration here. And more than anything, what we've got is a particular moment in time in which MHS can build on its strengths in ways that I think are combining the initiatives that are happening across the campus. So for people who might know this, it's not just MHS that's doing initiatives in health and society. We've also got the sociology department hiring in the Robert Wood Johnson program. History is doing a history of science search. So we've got a number of issues. So let me just say in sum so far that the point I'm trying to make is that the growth of MHS reflects the evolution of a particular form of knowledge. It's not just something that's happening at Vanderbilt. And that knowledge is also reflected in the structure of academic institutions. So I think those are the two key points that I'm trying to make here. In my last 10 minutes here before we can kind of open up to conversation, I just want to say a bit about what I think that history and that background tells us about the ways in which we might want to think about moving forward as we grow to build MHS. Now, I think that, again, there's tremendous effort here, there's tremendous strength, and so really as we think about the next steps for MHS, we want to grow on what works. And what really works here is the buy-in of the community. And so people have been generous with their efforts and supported for their efforts, hopefully, and we really want to retain that particular structure. But I think we also need to identify some of the core skills and concepts in order to shape what we're going to do with the curriculum. We also want to expand our connections within Vanderbilt, and we want to develop a larger national profile. So I would say those are the kind of four main goals for MHS. Now, again, as I mentioned in the beginning here, the key point of all of our initiatives are that we're trying to create a broader community. So this lecture really is an invitation to anyone who is not involved in MHS to please come hang out with us, and for people who are involved in MHS to please continue to do so. And I'll say a bit about initial already, but I'll just say the key things that we've done so far. First, over the course of the summer, we've revamped our website. So I welcome everyone to please visit our website, and when you click on it, just say like, oh, wow, that's an awesome website. We did really put a lot of time into kind of thinking about the website, and you might also, after you check our website, then I will freely admit that you can go to the Gates Foundation, because we kind of cribbed their design and layout because we wanted to look kind of open and welcoming, but we sadly don't have as much money to give people as the Gates Foundation. But we do hope the website will become an interactive node where people can come and kind of check out what's going on with MHS. We're also talking seriously about our undergraduate curriculum. Again, we want to maintain all of our strong alliances and, in fact, to grow new alliances in our undergraduate teaching. But we also think that the way that the MHS curriculum has formed has led to certain gaps, for example, in health economics, in studying specifically the interactions of race and health, possibly in gender studies, etc. And so over time, what we hope to do is to shape our curriculum that will be expanding into particular tracks. Now you might see from the list of just tracks that I thought up and I've been kind of working on that these tracks are hopefully not disciplinary. So we don't want to repeat, the history of medicine or the sociology of medicine, things that already are happening that we're in conversation with. Instead, we want to shape our curriculum in ways that will allow for people to kind of form different interests, but that are maybe not so disciplinarily based. Another initiative that we've been working on is the advent of a program-specific assessment instrument. Now, hopefully you roll your eyes when I say that. But I would say that I've had some pretty interesting experiences over the course of my career with assessing curricula like the one we have in MHS. And I will say that it's just a particularly challenging question, which is really, how do we know what we're doing in MHS works? What are the key competences that we hope to teach people, and how can we test those over the course of the curriculum? Now, I've undergone a kind of conversion about evaluation. I didn't start off as an evaluation person, and in fact, I will say that at the beginning of my career, I probably thought that evaluation was an intrusion into the kind of aura I was trying to create in my classroom. But I had an experience at Michigan where in the program we were developing, the Culture, Health, and Medicine program, we really were a curriculum that was based in trying to teach people about race and health. And we developed a series of two kind of curricular, kind of evaluation tools, a series of tests that we might be adapting here. One was what was called the Social Identity Inventory, and that was an inventory that was, we had classes on race and health, so it was like, do you feel racist? Do you feel like you harbor racist feelings? How do you consider yourself and your identity? It wasn't quite as crass as that, but it was along the lines of that. The second one was called the Cultural Biases of Health Survey, and that was a particularly skills-based questionnaire, and we basically gave people these tests that said, can you identify the cross-cultural components of a vignette? Can you identify different points of view? Can you identify that the voice of the narrator is not the only voice constructing a story? So in other words, skills that are central to, sociology and literature and in relation to race. And thankfully, what we found after testing our entire curriculum was that basically nobody's identity changed whatsoever. So nobody became any more or less racist because of our curriculum. Nobody became any more or less sensitive. Now, maybe that happens, but I felt like incredibly comfortable that our role as teachers was not, maybe it is to change identity in a particular way, but not in line of deep core identity. But what we did see dramatic improvement across a curriculum of social sciences and humanities and courses were in the skills that people can involve, the competencies where people could actually identify aspects of race and health that were themselves things that were in line with what we were teaching. And for me, that was a kind of particular aha moment, that in a way evaluation can help us identify these particular skills about our teaching that might be ambiguous otherwise. And so what we're doing in MHS is we're developing a new evaluation strategy that's taking some of the core competency material from the Association of American Medical Colleges and trying to develop an evaluation plan that tests some of these skills that have been deemed to be important to doctors, trying to test those across our curriculum. More about that later. We're also thinking about our graduate program. Again, our graduate program right now rocks in that we have great students, but our graduate program is also freestanding at the moment, so people are getting terminal masters in MHS. And I'll just say, I don't want to kind of go on about this too much, but I think our long-term goal is to somehow integrate the MHS masters into departments, if that's possible. And it was, Matt and I were having a conversation. There actually have been initiatives about this in the past. And we'd like to restart the question of, can the masters in MHS be integrated with different departments and schools across the campus? Again, a lot of text here. I apologize. Don't read it. This is like the cardinal sin of PowerPoint is you put up a bunch of words. I'll just say that this is the job search we have out. I'm happy to send it to anyone if they want it, but we are searching for faculty. So we're also going to have lines in MHS. We've hired one new faculty person for next year already, a junior medical anthropologist, Ken McLeish, who works on ethnographies of the military. He was at Fort Hood for a year. And we've got two searches out, one for a junior person and one for a senior person. And if you don't read this, or you'll have like a headache or something like that. But I will say that if I send this to you, and you please feel free to send this on. But we're framing this very widely. We've also got to search out for a grants manager. And so we're hoping to increase the grants capacity of MHS. And really, we see this very much as a community resource. We're hoping that we become a place that helps other places get grants in a way. So if people are working on health-related themes, hopefully you'll get to kind of come and we can help you kind of develop your grant. I'd hope to make the announcement about the grants person now, but we're actually down to our final several candidates, and there'll be an announcement about that soon. We're also developing an MHS speaker series. So we've got the sociologist Alondra Nelson coming in November to talk about the Black Panther Party and medical activism. And then in February, we're starting our first in a series of collaborative conversations with psychiatry. We're bringing in the medical anthropologist Raina Rapp, who has in the past worked on testing, maternal testing, but is now working on kind of neuroscience, and she's doing these terrific ethnographies of parents of children with ADD and Tourette's and on the spectrum. And so hopefully that'll be the first in a series of collaborations with the Department of Psychiatry. We've also got conferences that you'll be hearing about. So we're hoping to have a conference in the spring of this year looking at the local politics of health in Nashville. And then the year after that, we're hoping to broaden the frame and look at the ways in which the themes from the first conference will help us talk about national politics along the lines of the Michelle Bachmann stuff I was talking about before. We've also got a conference coming up on community health for our students, and that'll be in October. And the last part that I just want to announce is that we're also developing a series of a consortium of similar programs across the country. So part of our efforts this summer were to say we're developing all of this stuff in MHS, but we'd like this to be in conversation with a series of national and international partners. So we sent query letters out to the institutions that are listed below. And the idea is to build a consortium, a network of students and scholars that will help us further this conversation about medicine and society. And our plan now is to partner with these guys to do a series of conferences. We're writing grants for student and faculty exchanges, and we want to have a student essay contest. And actually the first of these will be coming up this year. We're doing health journalism panels at NYU and Vanderbilt. We're doing structural competency, really race and health conferences at NYU and Vanderbilt. And we've written a proposal for something at Melbourne, a kind of curriculum development at Melbourne. And the very last piece is that we're moving into a new structure, a lovely new structure. In 2012, we'll be moving into Calhoun Hall. Now, according to the powers that be, we get to choose our architect for this. And so we're negotiating with Frank Gehry. I mean, he hasn't actually written back exactly yet for whatever reason, but we're hoping to do something along the lines of his building in Prague. But I will say that if that doesn't work out, we're going to have another architect who we'll work with who will help us revamp the third floor of Calhoun. And so, in sum, I just want to say that, I mean, this is an inside joke for people at MHS, but the reports of the demise of MHS have been greatly exaggerated. We are seeking to grow and we are seeking to partner, hopefully in new and productive ways. We want to foster new connections in ways that build upon existing strengths. Two final notes before I finish. One is a note of thanks. I'm only standing here because of the tremendous efforts of people in this room who served, Matt and Catherine as directors, and Arlene couldn't be here today, directors of this program, and a great number of faculty who have contributed their time and efforts. And I really think that we owe these people a tremendous amount of gratitude for their efforts in building this program, really from the ground up. And I think that that's a tremendous thing. And I will just say that we have now a series of questions for the future, which is how do we grow? How do we go forward? What things are possible at Vanderbilt? And so we're thinking about new collaborations, new brown bags, new manuscript workshops, new events, new partnerships with nursing or the School of Law, more social events. And here are just a series of framing questions that I think were present on the flyer, but really the question is really the last one, which is, what is the important role for centers at Vanderbilt? And how might some of the themes that I've been talked about here play out as we grow over time? So I will stop there, and hopefully we have some time for comments and questions. Thank you very much. Please.
My name is George Hill from the medical school. First of all, I really appreciate your presentation. It was really very, very helpful. When students apply to medical school from Vanderbilt, a significant number of them are MHS majors. And, we look at that as a real plus. My question deals with the community that you referred to. Could you comment on your thoughts on how this center can have a really positive effect on the disparities that we have around us in terms of North Nashville? I noticed that you do have some potential collaborations with Meharry.
Right.
But in a general sense, what do you see is the role to help address health inequities here in our community, and what community means to you in that sense?
Well, I just love that question. Thank you so much. So if people didn't hear, it's really what's the relationship between a center at an institution like Vanderbilt that's looking at the politics of medicine and a community that really is suffering the downstream implications of the politics of medicine in this country. And so I hope it was not an accident that the first of our conferences this year is going to be about the question of health in Nashville. I mean, Nashville is such an interesting microcosm of the politics of health in America. It's got tremendously disadvantaged people who may or may not have access to care. It's got health insurance industry, pharmaceutical people, major medical center, historic black medical college, all these. And so the question for me, again, coming in as a northerner, we might say, is how is it that those things exist in ways that better this idea of what the community means? And so I'm not trying to repeat I guess I am trying to repeat your question a little bit, which is to say that this question of what the Nashville community means is incredibly, incredibly complicated, and we're trying to address that. Now, our interactions with Meharry are going to really take off because they're going to help us plan a couple of these conferences. I'm going over there to lecture, and my own work looks at health disparities in Detroit in mental health. And so I would definitely see that as a growing area for us, because I think that it is part of the social mission that we're going to address. And I think that the local politics here are things that they're kind of hidden sometimes behind these big structures, Meharry, Vanderbilt, et cetera, et cetera. So how can we kind of get a productive conversation going in relation to that? So I would say that I don't have an answer for you right now, except to say that if I don't have an answer for you by next year, one of our key agendas will have failed. But I really welcome any thoughts about that, please.
Would you comment for me on the relationship between politics and medicine, both local politics and national politics, and how that relates to health economics at the local level and national level? And is there a role for the center in the health economic debate?
Well, one of the, so we're going to be joined next year also by a bona fide health economist. So we will actually be entering the debate on a curricular level, and that starting next year will be, so I just want to say for the students here, we'll be actually teaching classes and hopefully partnering with people who are interested in this in the business school and other areas, but we will be on a curricular level. I mean, it's been, as I mentioned, it was in one of the slides, a missing point, I think, in our curriculum so far, which is that the debates about health and society and medicine really are playing out, obviously, on an economic level right now, and they're playing out particularly right now as, super committees decide the future of Medicare and Medicaid. Now, of course, there are expert centers at Vanderbilt that are dealing with that particular question, and so we're not going to bill ourselves as, we are the home of, of that. But I will say that that's going to be, I think, again, tremendously, tremendously important, because the question of what the politics of medicine mean, and I'll just use just a small example, which is even what Michelle Bachmann's talking about, even what people who are shouting out about critiquing Obama and stuff like that. Of course, those are financial arguments that are couched as political arguments. But I will also say, because we are also a social science and humanities center, that hopefully as we address those issues, we'll be addressing them in a way that that's maybe a bit more creative in a way. So what we hope to do, I think I just ran the battery out there. What we hope to do is to bring in the perspectives of the humanities into the economics debate, bring into the perspective of history. And so I think a place to get a bigger contextual picture of the economics of medicine really would be something that MHS would be particularly strong in.
Hi, I'm Barbara Clinton, and I teach a course at MHS. I'm the director of the Center for Health Services,
Great.
another center on campus, which was actually formed in the late 60s, early 70s to help students understand and relate to the interaction between poverty and the larger academic enterprise. So our work with MHS up to now has been largely to provide a research-based field experience for students to help them understand that relationship with poverty and act upon it in a systematic way. So I'm wondering what your vision is for that kind of experience for MHS majors.
Well, can I ask you how you felt like that interaction has gone?
Well, we've been actually very pleased with it. On the one hand, the students are doing real-world research projects in partnership with communities like the ones that George mentioned that are suffering the impact of exploitation in one way or another. So the students are actually using their academic skills to produce something that is used at the community level. But the students are also learning to formulate questions related to community health and the impact of health policy. So overall, I think we've been very pleased with it.
So I'll just say what I hope to avoid is what I've called center overlap in a way. So in a way, because like it's often happened to me, it's happened to me everywhere I go, where it's like, oh, here, I'm in this center and we're doing this great thing, and then somebody said, oh yeah, they're doing that in that center too, whatever. And so I think that, in a way, first, just at a meta level, how is it possible to create some kind of conversation really between programs and centers, and obviously departments and disciplines as well? But that's why one of the last slides I had was, can we have different levels of brown bags and grant research colloquia and faculty colloquia and stuff like that. So I think that centers, again, the natural impulse for centers a lot of times is to become circumscribed by design and stuff like that. But I would say that I would think that we would want more interaction along those lines between and among centers. And also, I'm coming in part from a service learning background. In fact, I'm flying off tomorrow night to DC. I've been part of the service learning component of the association, the American College Professors Association, looking at really service learning. We're part of this thing called Bringing Theory to Practice. And so I'm hoping to bring some of the Bringing Theory to Practice people down to talk to us about ways to enhance community engagement. And it actually relates back to the first question as well. And so I would love it, again, if we had more of that. So please follow up. Yeah.
My name is Pietro Valgassi. I'm a new faculty at the Mechanical Engineering. I'm working on robotic surgery and medical robotics. So how would you see the impact of robots in medicine and
Do you mind if I ask you that question first? I think it's incredibly, I guess obviously there's medical informatics, but you're actually asking me about robots? Yeah. I think I'm totally pro-robot, let me just say. But do you mind if I asked you that question? I mean, because maybe there's obviously stuff I don't know. We love robots. I mean, we tried to hire a couple of robots, but they signed with MIT instead. But I mean, how might you answer that question? Because it's one of those questions I don't have a ready answer to.
I heard around that there is a new discipline called roboethics, which is going on and studies the interaction between robots and humans, especially in the field of a growing field interaction.
Awesome. You're hired, first of all. I mean, please come over. But second, you know, it's funny, but like, so I mean, again, I'm calling on different examples of kind of stuff from my past because to be honest, I've never built a center before. This is my first time, and so it's kind of like you build on your experiences and then you see what the strengths of the community are in a way to grow community, right? But I will say that one of the things I did, again, back at Michigan was that I was the director of this thing called the Rackham Summer Interdisciplinary Institute. We had this for 5 years over the course of summers, and I was a colleague of mine in nursing, and we had 20 professors and 10 grad students every summer. We were together for a month. The first 2 weeks were readings about interdisciplinarity, and the second 2 weeks were developing communal projects. And we had a lot of people from mechanical engineering, chemistry, hard sciences, humanities, et cetera, et cetera. And then we would pick a common theme. And one year the theme was the body. And we had all this amazing stuff with people who were doing robots and mechanical models and stuff like that that really influenced, I mean, it was a tremendous interaction between the mechanical engineering people and the humanities people that came up with these really profound body models. And so I would say that I really was, you know, really taken aback by those experiences. And I do think that that's a kind of counterintuitive connection that would be incredibly useful to, in a way, replicate here. But I would also say, I had a slide that I kind of glanced over. I said good versus bad interdisciplinarity. And what I meant by that was that, you know, again, I'm not, you know, but I think it was somebody's vision at Michigan, a very interdisciplinary place, to say, we need to bring people together to collaborate in a way. And so they gave a lot of money for the summer to create this research institute where people were collaborating in ways that they never dreamed of. And then we did outcomes research after. We did social mapping afterwards, and actually collaborations enhanced after these institutes across these, you know, ways that you wouldn't have thought about before. Now, in a way, what drives me crazy about interdisciplinarity is when people say interdisciplinarity is based in a person, it's based in a scholar. You'll hear like, oh, that person is so interdisciplinary. You know, they think across these disciplines, and maybe that's true. I mean, there is something very personal about interdisciplinarity, but really interdisciplinarity is based in structures. It's based in visions. It's based in the ways that you enable people to be able to talk across disciplines. You reward them. You have grad students who have different committees. You reward interdisciplinarity along the tenure process. So in a way, there are structural ways, and for me, those structural ways promote interdisciplinary culture, you know, in a way that's much more important in a way than, because I mean, in a way, as a scholar, you are interdisciplinary as a person. So you know, really, I'm taking off on your question, but I will say that I think it's important. Please.
How much for the undergraduate students?
Oh, great.
Wondering if there are any specific changes you guys considered over the next 2 years in curriculum for requirements or anything like that?
Requirements. So really, I think, you know, my sense of the curriculum, I mean, in many ways, as I said, the curriculum is large. The curriculum is many things, and I think we want to retain those things. So I think that flexibility of the curriculum is something that's been a real strength of the program. I also think it needs to be shaped a little bit more. And as I said, we're going to be hiring professors in MHS to go along with the professors that we already have teaching. And so we'll be able to, I think, put a bit more of a framework about specific areas. And maybe we're going to, again, I was kind of saying maybe it's disciplinary, maybe it's not. But I do think that there will be particular tracks within the undergraduate curriculum so that people can say, I'm not just an MHS major, but I'm actually focusing in this track. So I just think we're going to give the undergraduate students a bit more guidance while hopefully retaining the flexibility. And I know that's a vague answer, but part of the reason that it's vague is because, as I mentioned, our new faculty are going to be coming in, and we want to play on the strengths of the people who are coming in as well.
Do you have like a timeline for that? Or is it
Over the next couple of years, I think. I mean, I thought we could do it all over the summer, but I found out that actually I just had to find out like where the cafeteria was over the summer, stuff like that. So yeah, but I think it'll be happening slowly over the course of the next couple of years for the curricular design. Stefan?
Jonathan, I'm intrigued that you focus on structures as an ingredient for interdisciplinarity. So would you agree that within your field of medicine, health, and society, there is a gradient of how you can move towards a interdisciplinarity? Would you agree that economics and natural sciences at this point force our thinking about medicine, health, and society more than others? And if that is true, that there is a gradient, that they will take the lead and others will follow, how do you envision structures to offset such an imbalance? Because the money and the natural sciences so far very much driving our concept of health and disease.
Right. And can you say, so when you ask me that question, you're saying that basically the structures of the academy reflect.
Should the structures simply reflect it, or should the structures be built to, in some way, address, critically reflect on those?
I mean, we are also, again, calling on methodologies from sociology, anthropology, from the humanities. So in a way, the foundations of one of the disciplines that I'm standing here representing is what's called medical humanities, which has grown to be a very broad term, but in a way it's coming out of a theoretical model that actually exposes structures as a way of critiquing them. And so I think that partially, just in terms of leaving aside the question of the specifics of kind of medicine, health, and society writ large, that in a way the discipline itself is, there's always going to be a tension. I mean, there really is always a tension at any institute or department that tries to exist between what we might call a professional school and a humanities school, for example, or something like that. There's always going to be this particular tension about the flow of money, about the flow of knowledge. But I would also say that I feel very confident that this particular discipline is grounded in both, in relation to, again, sociology, anthropology, humanities, disciplinary structures that expose structures as a way of talking about power imbalances, really. And so I think that that's always going to be part of our particular conversation. But of course it's hard because, there is this utilitarian question of what good is that, what use is that? And I'll just give one example of this. I mentioned before that the model that we're working on for one of our conferences is what's called structural competency. And what we're trying to do is rethink what has been called cultural competency up until this point in medical education, which is this idea that we're training doctors to be more cross-culturally sensitive or culturally aware. Now the initiatives on cultural competency, which again are important, they come out of an awareness of diversity issues in medicine, but the efforts very often are geared at doctors. Being more sensitive to the racial or ethnic backgrounds of their patients, which again is incredibly vital if you're going to a doctor. But the argument that I think we're trying to make, and what I'm doing and some of the work I'm doing, is to say that if you're just making this about the observations of the doctors, that what you're doing is you're missing how so many issues that arise about kind of race-based health issues or disparities really are structural level issues. So you need to look at schools and exercise facilities and grocery stores and funding mechanisms. And in a way, those structures have been invisible, to my mind, from the discourse on cultural competency. And so what we're trying to say, and I've been talking to people at the medical school and other people about this, is that in a way, we want medicine to become more aware of structural issues and how those impact the symptoms that patients might come up in with. And so in a way, it's kind of reading in tension with your question, because that's actually using a method from the humanities to make structures more visible to doctors. And we're playing around with like, okay, if that's true, how can we expose the structure to physicians? And so again, this is a long-winded non-answer, except to say that I think that there's always going to be a tension around that particular issue, because you're both reifying and critiquing structures of power. Richard, yeah.
You mentioned earlier the AAMC changes that were taken in 2015 in terms of the MCAT. And I think the way I count, that means our freshmen entering next year will be affected by that if they take MCATs at the end of the junior year. I've been very interested in some ideas that George Hill has shared with me about how many potentially wonderful physicians we lose because of the hurdles one has to jump over to become eligible to take the MCAT. Do you have any ideas about how these new requirements can be folded into the training, especially that MHS students receive? Because most of the complaints you hear from, at least most of the psych majors I've dealt with over my career, I don't want to take statistics, don't make me do it. And it ends up being one of the best experiences they can have. But also, how do we look at the traditional so-called hard science core components that make up those two unspoken parts of the MCAT that you didn't mention?
Well, I mean, I think it's a really interesting question. First, let me say I have no direct involvement with the MCAT, and I don't know the answer to your question from a practical level, but I will say that it does raise a series of important questions that I think are really going to be important as we, as a university, strategize about how best to prepare students for that exam, but also that, which is, in a way, what you're doing with this formulation of MCATs is, just at a base level, like before students just needed to know science, now, which I think is a good move, but it'll be interesting to see how it plays out. Now they need to know psychology, and they need to know social science, and they need to know humanities, and they need to know history. So in a way, you're just expanding the number of disciplines. And so I think it's a really key question, which is how will that mean a cutting back on the sciences? I kind of doubt that that's particularly the case. But what do they mean by that particular integration? And I think that'll be the really key issue. Now, let me just say, as I think was clear, I think it's great that they're doing this because I do think that medical education has been too invested in memorizing facts a lot of times, and those facts change over time. And so we're left with students that have a dated knowledge base. And that's true not just in terms of pre-med, but in terms across the kind of medical education spectrum. And so the question will be, which I think is important, will the emphasis on critical thinking lead to a de-emphasis on the memorization of particular facts? And I think that'll be one interesting question. But the other question that I don't think they're thinking about maybe that much is that there are these 4 areas. But humanities methods, as in line with kind of Stefan's question and other people's questions, sometimes are inherently skeptical of scientific facts. I mean, that's the core of the social studies of science and other things. And so, in a way, what will it mean to put the facts that students are memorizing under a particular form of erasure, as we're also asking them to memorize? And I think that this is the very beginning. Let me just say, I love you all, but I feel sorry for the first students that, no, I'm just kidding. I think it'll be worked out. But I do think that these are a series of intellectual questions that are not just about the MCAT. It's also about core competencies for medical school that are changing. I mean, medical school is emphasizing community involvement. But, what happens is, you see this with medical humanities. The methods that they're employing are at times inherently critical of the project that they're in the service of. And so how does that play out? Maybe it plays out in terms of economic power structures, but I think that in a way this is the beginning of a conversation that's been happening, and Stefan can tell you it plays out even at the level of knowledge production, like constructing the diagnostic and statistical manual, where there's this need for facts versus critique, and how can we manage that? And again, this is not just a medical issue. Reading the other way, it's also a humanities issue, which is a re-engagement of humanities with facts and neuroscience. And I'm part of a neuroscience collective out of CUNY that's really looking at this question of what is a fact. And it's almost more scientific than, it's certainly past my knowledge base at this point. So I think this is a moment where these things are being engaged with in important ways. Yeah.
In the MHS program, will we see like a specific integration between MHS and neuroscience, as tons of research is coming forward that says poverty and then different SES has a direct effect on neurological processes, or just the, just the systems in general? Will we see like a strong bridge between them in terms of research or in terms of classes, or one of those tracks?
No, I'm just kidding. No, I would say, honestly, I would say that I would love that. I mean, I'm a psychiatrist and in the psychiatry department, and I would also say that I mean, maybe it would be helpful, just based on your question, I hadn't thought about it, but there is this whole critical neuroscience network that's based largely in New York, which are humanities professors engaging with neuroscience. And so it might be interested. I mean, I said that we were inviting Raina Rapp in to kind of get that conversation going. But I do think that critical engagement with neuroscience and looking at similar issues across different disciplinary perspectives is something that's really happening in neuroscience right now more than any place. I mean, religious studies is engaged with neuroscience, bioethics, obviously, economics, neuroethics, et cetera. And so I think that hopefully will be an area where we can, I mean, you know, it's a great question because I think we can actually create some points of common interest. So that's a great question. Great. Well, I think we have some light refreshments outside. So thank you all so very much for coming.